So the one comment that I had was looking at the title of my talk as I was giving it, looking at the history of hospice and the contribution of palliative care, and whether that's the contribution of palliative care to healthcare or to this whole endeavour that we're currently involved in. To me, everybody here is involved in palliative care. And palliative care is compassionate care of people with life-threatening illness from when they're diagnosed, but a lot of the work that we've done in hospice has been kind of end-of-life palliative care. And I am just so excited and so thrilled to see how many people are looking at how they can contribute to making that experience a kinder, more fulfilling experience, because a lot of people have said to me, why are you in palliative care? Isn't it so depressing? It's in fact the most important part as a doctor of what we do, and it can be absolutely transcendent. And I am so grateful to the patients I've worked with, the families I've worked with, for the learning that I've been able to do from them, partly from their courage and partly from the way that they do transcend the most amazing experiences. So, just to go on, am I using this?
Yeah, you're going to use that. Sorry.
Okay, cool, that's fine. So I just thought, because this is about hospice, I'd go back to, and of course they talked about places for the sick and the poor way back to the time of the Crusades, but hospices, 1943 is the first time that they talked properly about hospices, but it was really for hospital for the poor. So when we're talking about care of people who are dying, and I've taken out the term terminally ill because I think it's a horrible label, and we have to recognize that a dying patient is still a living person, and make sure we celebrate and help that person. And then the Sisters of Charity opened Our Lady's Hospice in Dublin, Ireland in 1879, and then opened St. Joseph's Hospice in London. And it was St. Joseph's Hospice in London where Dame Cicely Saunders started her work in palliative care. But she opened St. Christopher's, which is celebrated as the start of the modern hospice care, in 1977. And look, she trained as a nurse. She got terrible back pain. Nurses here will have that resonate, how difficult it is. So then she trained at what was then called an almoner, a lady almoner, which is a social worker. And then she knew that she wouldn't be taken seriously in the clinical profession unless she was a doctor. So she called herself a one-woman interdisciplinary team. So, and then she had this amazing friendship with a number of Polish people and eventually married a Polish man. But David Tasmer, she looked after at St. Joseph's in 1948 and talked about her dream to have a home to care for people who needed that care. Of course, what I believe and what we aim for is for people to be able to be cared for in their own homes. That's really, I mean, dying shouldn't be a medical thing. It's something that happens to us all. So anyway, he left her, when he died, he left her £500, which was a lot of money in those days, and said, I want to be a window in your home. So that was the plan, and that was how hospice started and was founded. And Dame Cicely Saunders was the person who first described that concept of total pain, that it's not just physical pain we have to address, but the emotional pain and the social and spiritual dimensions of pain. And Myrtle, you described that to me so eloquently this morning, that that's what we are left with even beyond the actual care of people who die. And this comment, which is still true, unfortunately, how many years later, that many patients feel deserted by their doctors at the end. And ideally, the doctor, I don't know that I believe should be the center of the team. In our hospice work in South Africa, it's been the nurse and the social worker, in fact the patient at the center, but the nurse and the social worker who are leading that care. And then the team works to relieve where they cannot heal, and to keep the patient's own struggle within his own compass, his own life experience, and to bring hope and consolation at the end. So those wonderful aspirational comments from Dame Cicely. And then, of course, Elizabeth Kubler-Ross, who published on Death and Dying, and whose work on the stages of grief, which we recognize aren't like set stages and you go from one to the other, and how many people actually reach acceptance anyway. Although, having said that, there are so many people who have beyond acceptance, that transcendence that I spoke about. And in fact, she greatly influenced Cicely Saunders, and Cicely recognized that the year that David Tasma died was also the year that her father died. And she said, I was suffering from pathological grief. So she brought her own experiences to assist us so much in what we do. So in South Africa, we've also been led by hospice champions. So I want to recognize that Island Hospice in my home country of Zimbabwe was the first hospice established in Africa. And then Stan and Shirley Hennon started Wits Hospice, the first hospice, and you look and see that they started it in their home, and Greta Schoeman in Durban started hospice care in her home, and Greta was recognized by the Queen and given an MBE for her services to people at the end of their lives. So that recognition has already happened. And here in Cape Town, Christine Dare, who'd worked with Cicely Saunders when Christine was a physiotherapist, and Cicely said, you won't be taken seriously unless you're a doctor. So she came in as a mature student. She was in my class at university, and she qualified as a doctor. And I always say her Alsatian dog actually attended more lectures than I did. But then she established St. Luke's Hospice, and with a very strong, firm clinical emphasis and foundation. So when I talk about hospice palliative care, and for how many, 12 years I was the CEO of this organization. It was established in 1987 when there were only 15 hospices in the country, and it's really, the intent was to share best practice from other hospices and actually to be a voice and to advocate both within communities, within healthcare, within the government for better care. And then we changed the name to include palliative care because that describes what the hospices do. And it's looking for quality care, training and education, and our hospices have led in training and education in palliative care, but to make sure it's quality. So standards of care, standards of management and governance, and we worked very strongly with the government to say we have to have palliative care in every health establishment, in the frail care sectors, in old age homes, and children's homes, so that it is absolutely available to anyone who needs it. So this, what is palliative care? And Sean's disappeared just when I might need him. The formal definition is that palliative care improves the quality of life. That's the goal of patients and their families facing problems associated with life-threatening illness through the prevention and relief of suffering. So look, we can prevent suffering as well as relieve suffering by early identification, impeccable assessment and treatment, so real attention to detail of pain and other problems, physical, psychosocial, and spiritual. But Professor Derek Doyle puts it in a nutshell. He says, palliative care is the relief of suffering. So I just want to show you a video which I think I have to flip to the next. Will it go?
Sorry. Oopsie.
And it's a video that we use a lot in our teaching, and it really assists people to understand. It's talking to patients and families to understand what is palliative care.
You are a bridge. It's true. Or at least
why we need palliative care stations. So let's go back to number 8. on another version. That's fine.
Sorry. Sorry, just try and click it in. No,
No, let's do it at the end.
Okay, sorry. Apologies.
Okay, the next button.
There.
There.
Yes.
It's nice.
Next one. Come on. Sorry. Too many windows. Yeah.
So really the things that I wanted to emphasize are that palliative care is about quality of life, that there are those four, but you can expand those domains of physical, social, emotional, and spiritual or existential, and the unit of care is patient and family. It's not a person isolated in a hospital, kind of divorced from the family, and the family in the widest sense, so close friends and partners and whatever. And that the patient-centered care can only happen if we have really good communication skills, and the three most important aspects of communication skills are listen, listen, and listen. We want to understand the person's experience. So, and this business of holistic care, and that there's active management. A lot of people thought palliative care was withdrawing of patients, of care. So here, look at all the other things that it says that palliative care is. I'm not going to go through them all, but really looking that it affirms life and regards dying as a natural process. As I said before, why are we dying in hospitals? It neither intends to hasten nor postpone death. So it's looking at facilitating that natural process through impeccable care. And palliative care can be provided wherever the patient is. And that, for me, as a healthcare professional, is one of the most exciting things. You don't have to go along to the hospital and sit in queues and wait for your doctor, or go to the GP and he's running late. Care comes to you wherever you are. In the home, in the frail care centre, children's homes, hospitals, a hospice inpatient unit, if that's where you are. And I wanted to touch on dignity. And a wonderful man, Harvey Chochinov in Canada, has done work on dignity, and he's got a special research unit on dignity for decades. And he talks about the fact that illness, and in particular, life-threatening illness, threatens a person's sense of health. And he says that loss of personhood can result in a sense of despair. And he challenges all clinicians to ensure that they bring their own humanity and compassion to healthcare delivery. So I ask always, my students, my colleagues, how are patients treated in the healthcare system, public and private, in this country? Is it with respect and compassion? Is it with indifference, just another prostate cancer, just another breast cancer, we see them every day? Is it with rudeness? How many people don't complain because it's been with really kind of aggression and rudeness? So the thing that we need to remember, that it's important to affirm a patient's value as a person, and to help them in maintaining or restoring their dignity. Because often it's how they've been treated that makes them think that they're worthless. We have to re-establish that sense of self-esteem and self-worth. So in palliative care, how do we do that? Through respect and compassion. That we take into account patient preferences, and that the patient preferences and choices and their health, their life experience guides our development of a care plan. And the easiest thing for me is the physical. The control of pain and other symptoms. I can manage to control cancer pain within 24 to 48 hours. And people say, but you know, we have to, for example, there is a move to legalize euthanasia because of unbearable pain. That should never happen. That is the worst form of violation of a person's human rights, to offer them death instead of care and management of pain. The psychosocial, the preservation of the sense of self, the self-esteem, and the strengthening of relationships that happens at this incredible time in a person's life, that's a whole lot more difficult, and I really compliment my colleagues in social work and in the psychological counselling for the incredible work that they do in ensuring that this is true. And then the spiritual. So also our spiritual counsellors, looking at the existential distress and allowing people to, and listening to them and exploring with them so that they can find that sense of spiritual peace. So the issue with serious illness is it absolutely disrupts our life story. And our whole view of the future, our plans, our goals, our personal world is just shattered. And doctors try to restore the old life and put it together. You can't ever. It's changed forever. So the role for palliative care is to help people re-script their life stories for however long that script is. And people adapt to the circumstances they experience. So we need to understand that our help is to help them adapt. And this slide that I took from Reverend Christian Bush in Denmark, he talks about the discussions that the social workers and the counsellors, and we hope the doctors and nurses are having, is about the fact that people swing from wanting to know everything, and I don't want to know, from seeing the benefit of actually being in a care situation and feeling that incredible feeling of loss, of hope, which in palliative care we try and enhance realistic hope and not the false hope that is often given by the medical profession. And then the realism, this is how it is. The will to live, the wish to die. The revolt against what's happening, and the submission, the acceptance. And feeling that I want to be in control, so that's one of the things we try and do with a care plan. These are the things that we can fix, and these are the things that you can do. If you want morphine, do you need a slightly higher dose? Do you need a lower dose? Do you need to say, I need a dose before my dressing change or before I go out to the shops? Those kinds of things, having that. And look what he also says, the swing between joy and sorrow. And I'm going to make the statement that when life is short, when time is short, life is precious. Every moment is precious. And where can you find the joy in those moments, provided you're not in pain and with any other form of other physical distress. So the end-of-life decision-making is often made in an environment of emotional distress, and we need to be sensitive to the human vulnerability, dependency, and fragility of the patient who's critically ill. And the other thing we need to be comfortable with is with uncertainty. A person will say, doctor, how long have I got? I actually don't know. I know when it's a couple of days, but I don't know if it's months. I don't know if it's weeks. So that uncertainty, so if this happens, this is what we're going to do. If that happens, that's what we do. And it gives people a sense of security and being held, and especially that promise of non-abandonment. We'll always be there to help you. And we need to do that planning for different outcomes. So I just put in a little bit of ethics because that's what guides a lot of our decision-making at the end of life. We do support patient autonomy. We recognize that people change their minds. And in order to make decisions, they have to have all the information, and their autonomy is compromised if they're in pain or distress. So let's sort the pain and distress out and enhance their autonomy. We want to benefit the patient. We want to do no harm, and what we're trying to achieve, especially in palliative care in South Africa, is equity, is distributive justice. And a colleague of mine who works in the public health sector in oncology says, so equality is where you all have got the same kind of stage. Equity is where the people, the shorter guy gets the higher box. In South African healthcare at the moment, the people with the haves have got have, and the people with nothing have got very little. So we're looking at trying to make sure there's quality and access and low cost for everybody, or no cost for the people who can't afford that care. So we want to develop care plans relevant to the individual and the stage of the illness and the person's preference and the family's wishes. And if it's a shared decision, then we can achieve appropriate patient care, because the patient and the family are contributing to those decisions. And you know, I looked for some pictures to kind of lighten this presentation. And the one where I looked at shared decision making, I searched through all of these images till I found a healthcare professional who was listening to the patient. The others are all about the doctor or the nurse telling the patient. Yo. I also want to bring this paper won the best paper at the last European Association of Palliative Care conference. It talked about interviewing people who were ill, about their experience of sympathy, empathy, and what was compassion. And the sympathy, you can see, is a pity-based response to a situation that is, how do I feel? Oh, I'm so sorry for you. If I was like that, oh, I wouldn't want to go on. Whereas empathy is more understanding and trying to relate to the person and have a kind of emotional resonance. Yes, it's very hard for you. What can I do to help? Rather than, I'm sorry for you, I actually don't want to. You know, people withdraw when people are sick or disabled or whatever because it upsets them too much. We shouldn't worry about our own upset. It's much harder to be that person. So how can we help? And this comment that compassion is the most potent form of care that healthcare providers can express. So the current situation, in the research that I did, I discovered that about 18% of people in South Africa are receiving palliative care when they need it. And that's palliative end-of-life care. That's not talking about the earlier palliative care. In 2011, there were 201 hospices in South Africa. There are now 108. And many struggle with retention of experienced qualified palliative care staff. And hospices, so I've got my I'll continue here. So the issue there is that hospices, even if it...
Do you want to use it as a prop?
Thank you. I'll use my outside voice. So even if there was a hospice in every town, hospices cannot provide all the palliative care that's needed, and you've heard that palliative care has to start early. So we have been working with the government and a little bit with the private sector, and in 2017 the government approved a national policy framework and strategy for palliative care, which is to be celebrated. But there's no budget. It's all going to ESCOM and SAA and whatever and whatever. Anyway, so we're trying to be... So this badge is the efforts of the Department of Health in the Western Cape for palliative care. And so there's a task team in the Western Cape that is actually showing how we can integrate palliative care into our health systems. This is the only province where it's currently happening, but we believe we've got a blueprint for it, and we are showing it at a meeting on the 21st of February where we've invited the National Department of Health to come and see what's being done. In Gauteng and in KwaZulu-Natal, the hospices and palliative care centres are training healthcare professionals in palliative care. And to me, I come from a university, I'm an educator. Education is the foundation. And it's not only training the healthcare professionals, it has been teaching and informing the policymakers, but also reaching into communities to say this is what palliative care can do for you. And don't be frightened about the word hospice or palliative care or morphine, because research has shown that palliative care not only improves quality of life, which is what we expect, it lowers rates of depression, and it marginally improves the length of good quality life. I mean, length of life, but with good quality. So where people think that, oh no, I'm not going to hospice because I might die there, the issue isn't whether you're going to die or not. The issue is what's going to be the quality of that dying. So really we need to be looking at that. So to end, we have to remember our goals. It's quality of life through the relief of suffering and support for the individual and family throughout the illness and beyond into bereavement care. And that comment I made earlier, that when time is short, each day is precious. Can we, all of us, ensure patient comfort to be able to enjoy this time? Thank you very much for your attention.